Okay, so you see that the analysis of clinical trials is a very complicated and tricky one because of you may have designed a trial to ideally do a perfect experiment, and you have complications that come from real life. And complications such as missingness, you have complications because you know you had estimated things to go one way, but that's not exactly what is occurring. And you are concerned that your investment of 1, 2, 3 years of your career or your life may come crashing down because of all of these problems. And so that's why we talked about the adaptive designs, and one of the adaptive things is adaptive stopping of the study. We saw that that was due to ethical reasons that we are forced to do interim analysis. You saw, yes, or you heard 2 days ago from Kumar of the complexities in having an external group of people do the monitoring. And there were several of you that were concerned, well, how does that actually work, right? So yes, he explained that the group will have a charter. They will be guided in their meetings and in what they're presented by what's in the charter. They will be given these guidelines of how you're monitoring. You're monitoring the processes, you're monitoring for futility, you're monitoring for safety, you're monitoring for efficacy, you're looking at the equipoise going away or not. You're looking for things that are happening in the study. You're looking at things that are happening outside the study. And it's a big role and responsibility for that. We were discussing with several of us that there is not much experience in India of people working with data safety monitoring boards and being members of a data safety monitoring board. In North America and in Europe, there's also many people do not know how these things function. And you say, well, don't you have these meetings? You have the open session, you have the closed session. You just look at the data and decide what to do. So what we wanted to do is to have a little exercise with you on how do data and safety monitoring boards may actually occur. This is a real study. It's called the Systolic Hypertension in Elderly Program, called SHEP. And what we're going to do as an exercise, we're going to pretend that you all are the Data Safety Monitoring Board. And we will pretend that I am the unblinded statistician that has prepared the report and that's presenting it to you. Now, so I will be the Kumar here. You will be the Data Safety Monitoring Board. And the way these things function is you are in charge. I am just the person that does the analysis and presents it to you. I, like any other human being, am a lazy person. I do not do anything unless you ask me to do it. I'm not going to start giving you this and this and this. Oh, you should know this. That's not the role of the unblinded statistician. The unblinded statistician is to follow the direction of the board members. You tell me, I would like to know such and such, and then I will produce that for you. If you don't tell me that you want such and such, then I'm not going to do that necessarily. I have my life. I have to be with my family. I have to do this and that. This is not my life to just do things and propose things to you. You make my life complicated because you ask me to do things. And if whoever you ask me, I'll say, yes, I will do it, because that's my job, is to serve you. Now, we'll pretend that you are the Data Safety Monitoring Board. That means that all of you, first of all, know the protocol of the study. All of you are experts whether you are experts in the clinical field, many of you are clinicians, also experts in methodology, many of you are statisticians, also experts in medical ethics. We'll assume that all of you are ethical and are keeping who in mind? The safety of patients as your main thing. You're also thinking about what I want to be making recommendations that protect the safety of people, but also the integrity of the study so that the results of the study would be impactful, not only to the people in the study, but people outside the study, okay? Now, I also realize that you board members meet only infrequently. You have other lives, professional lives, so you don't remember the details of the study all the time. So I'm going to remind you of the details of the study. This is a randomized, placebo-controlled trial looking at the intervention versus placebo. It's double masked, and it's looking at the efficacy of hypertension medication. So it's an antihypertensive to prevent strokes and other cardiovascular diseases. It's double masked, and it's in people that are older than 60. I'm not going to call them elderly because I'm in that group also, with isolated systolic hypertension. So isolated systolic hypertension means what? It means that they have high systolic blood pressure, but not necessarily high diastolic blood pressure. So it's isolated for systolic hypertension. It's a study that was well designed, well planned, and it's close to over 4,000 patients that have been randomized here. It was started in 1985. It's scheduled to end in January of 1991. And you have been meeting all along, and we are at a stage now where we are getting close to the end of the study, and we are also looking at the possibility of early termination because we have wanted to look at efficacy and to see if equipoise is no longer there. When the study was planned, there was no evidence that this particular anti-hypertension medication was beneficial in preventing strokes and other CVDs. Your primary outcome, I think your primary outcome. Yeah, I guess the primary outcome is coming. It's a multi-center study being conducted in the United States. You are the DSM, some people call it board, some people call it committee. You are the DSMC, that's how you are called. You are external. There's some cardiologists here, there's some neurologists here, there's biostatisticians, and I assume everybody is ethical. Now, this is a very difficult outcome to know whether it has occurred because we're looking at strokes and other CVD in people that are over 60. And so when there is a suspicion that a stroke has happened, if it's a strong stroke, people may die, or it becomes very evident that this has occurred. But sometimes it may be a mild stroke. Somebody feels dizzy for a while and then they go on. So sometimes they don't really know, but we have instructed in the study, all participants have to come in every 2 months for checkup, but also if they have any indication that they have felt something unusual, they can call and we will check on them. And there is an event adjudication committee because people are examined with a CT scan or an MRI. They also meet with a trained neurologist who follows the SHEPS protocol to determine whether you have had a stroke or not. They also are seen by a neuroradiologist that follows the same SHEPS protocol to see if you've had a stroke or not. Then you have also the medical history and the chart. And whenever there's a suspicion that you have had a stroke, so that you've had the event, then all of these things are done. They're collected. They are then sent to a committee of that's called the adjudication committee that looks at all of this information by two separate people on the committee. And if both of them look at it, follow the same SHIP protocol, and if both of them say, yes, this was a stroke, then it's a stroke. If both of them say it's not a stroke, it's not a stroke. But if one says yes, the other one says no, then the committee meets, the entire committee, and they discuss. There's 5 people on the committee. They fight it out, and they come out with a verdict for that case, yes or no. So it's a very complicated process to do this adjudication. But the study determined that it was important to make sure that the event occurred or the event did not occur. It is not time to event, it's whether it has occurred in the space of time. Now, I'm going to present to you, now you've come here for the meeting, I'm going to present to you the data as we have now, and I will present to you the primary outcome and some secondary outcomes. It's up to you to then ask me questions. If you don't ask me questions, I will stay quiet. If you ask me questions, I will try to answer your questions. Once you stop asking me questions, you have told me that you are going to make a decision at this meeting whether there is enough evidence that equipoise is gone, and so therefore we should stop the study early, or recommend stopping the study early. Or you will say, no, I don't think we should stop the study early. Now, the way the committees work, it's not one person on the committee deciding. It's not a vote, like 3 people say yes and 2 people say no. They put that on the paper, but actually it works by consensus, which means that everybody on the committee has to agree or not. We're not going to do it that way. We're going to go by vote. So you will vote when questions stop. That comes the time when you will vote, yes, we continue, no, we don't continue. And everybody on the committee votes. There's no, I will look at you. If you're not raising your hand, I will say you're doing this or you're doing that, and we'll see what happens. Questions before we start? Okay. So we are at the July 1990 meeting, and here is table 2 of the primary outcome and secondary outcomes. We have, I'll remind you, that we had over 4,600 people randomized to active or placebo. And as you see, we have 2,365, so the numbers are a little bit off, 2,371 in placebo. The primary outcome is the one highlighted in yellow, and it's strokes as determined as definitive strokes by the adjudication committee. There's 85 in the active antihypertensive group. There's 119 in the placebo arm. So there's more strokes in the placebo arm than in the active arm. And if I calculate the proportion, it's 3.6% in the active, it's 5% in the placebo. So if I take the relative risk of placebo over active, it is 1.40. Now, I also am presenting here in table 2 to you, distinguished committee, the reported strokes. What are reported strokes? Those are where the sites have reported strokes, and they are, some of them have already been called definitive or not, and some of them are still in the process of being reviewed by the adjudication committee. So there are about 93 reported strokes in the active. There's 131 in the placebo. And so the risk ratio is 1.41. So despite having many more reported strokes, the relative risk is about the same in the reported versus the definitive ones. Now, you are also concerned about safety. Are we causing deaths in the placebo more than in the active? There are a few more, but the relative risk is only 1.09, so it's not necessarily a substantial amount of more deaths. Now, all of the strokes are not fatal strokes. Some strokes are fatal, and this is a secondary outcome. And the secondary outcome has that the non-fatal strokes are 111 in the placebo or 78 in active. So there's actually 8 fatal ones. So 119 versus 111 is 8, and 85 minus 78 is 7, right? So there's not very difference in the fatal strokes between them. But we notice also that there's more non-fatal MIs in the placebo. We notice that there's more transient ischemic attacks in the placebo, and we notice that there's more episodes of left ventricular dysfunction in the placebo. All right, so one at a time, I guess we should get questions.
Were previous interim analyses done prior to this meeting in 1990?
So yes, you had looked at it, previous interim analysis, but they were not formal interim analysis where you were looking at the efficacy of the intervention. You were just being presented the data, but you had not wanted to make a decision on it.
So the confidence intervals for the two arms for the primary outcome.
So the confidence interval for the 1.4 relative risk does not include 1. If I do the 95% confidence interval, it does not include 1. One at a time, son. What? Status of recruitment. We had planned 4,600, so we've already completed recruitment long time ago. Again, you have to speak louder or use the microphone.
It's completed, then why are we doing interim?
No, wait a second. The recruitment is completed, but the study is not complete. Oh, what is the stopping rules? Okay, hold on. Okay, so you had looked at it before, and we are here at about in information time, in the number of events that we needed. We are here right now, and we are at this point here. Previously, in other meetings, you were not doing any formal testing, but I had calculated for you because I'm a good reporting statistician, and I had saved that information, so I'm presenting it to you. Early on, the Z value was very low here. At your next meeting, it was there, it was here, it was here, and then it went here, and now it's here. So this is with the definitive strokes, which is the primary outcome as adjudicated by the committee. But I'm also being nice, and I'm showing you that all reported strokes is the little blue one, and they were here, they went here, 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 here. So they tend to go up and down, and up here. I also presented you deaths. Deaths, interestingly, there was a big difference in deaths, but that has been going down, and currently we are not at a very, we're way below even 1.96 for that. So there's not really any meaningful difference in deaths between them, slightly more, because it's not next to zero, but it is pretty close to zero. Do we have the causes of death? We have the causes of death, but you're interested in strokes as your primary outcome. That causes death. If you want the listing, they're in pages 50 to 100 in your report. You can look at them at your leisure.
About the safety part of it because of
Yeah, so the deaths due to strokes are only 7 in the active and 8 in the placebo. Because I would like to remind you that these people are elderly. They're dying of all sorts of stuff. They're dying from, car accidents. They're dying because they fall, they broke their hip, and they're frail. They're dying because of cancer. They're dying from other things. Those are unrelated to the study medication, and they're not necessarily. We were worried. You were worried about causing more deaths, but they were not. There's not a meaningful difference in deaths. Upper limit for age. There was not an upper limit for age, but the oldest person in the study was around 84 at baseline. Yeah. Go back to the graph. Yes. Okay. So the question is, are we in line with the protocol to stop the trial? Well, you were actually don't remember that in 1979, O'Brien Fleming published a paper. You adopted the O'Brien Fleming boundary. And so the O'Brien Fleming boundary, I will remind you, it's I'll use a pen. I see. I can't really see. Oh, yeah. The O'Brien Fleming boundary is like that. Can we have another interim? Sure, we can try to do it, but we had not planned to do that in your charter. You did not say that you were going to do another one. But if you would like to do it, I will be glad to wait 90 days if you want to wait 90 days.
In our protocol, had we defined that we will look at all strokes or definitive strokes as
The protocol said the primary outcome is definite strokes as per the adjudication committee.
That's the primary outcome, but for stopping the trial,
You were going to use definitive strokes.
definitive strokes.
So that's the
So
primary
then
outcome.
it's on the line of the O'Brien
It's
Fleming.
just above the line.
Just above.
Right. There's one person at a time talking.
We can think of stopping it. I mean, I can put it up as a motion.
So she's putting it up as a motion to stop the trial. You other esteemed committee members, what do you think? Show of hands. How many? And I'm going to look at everybody because everybody has to either show your hands now or not show your hands. And then I will ask somebody, not randomly, that raises their arm, that say they want to stop, to tell me the reason you want to stop. And the people that don't want to stop, I will again, not randomly, choose one of you to tell me why you do not want to stop. Okay? Because everybody on the committee needs to think about it. It's not passive. If you're a member of the committee, you are actively involved in thinking about what to do. So, how long is the follow-up period? The follow-up period for each person was 5 years. So we are still about 9 months away from, or 7 months away from the end of the study. Okay. You are not withdrawing it from me. You're withdrawing it from your colleagues here. So you're convincing them because of that. So you are willing to let more people have strokes than in the placebo arm. There's a 40% chance of higher strokes. It's 1.4, which means 40% more risk of strokes in the placebo arm. If your mother is over 60 in this study and has isolated systolic hypertension and is in the placebo, are you comfortable with having her be exposed to that high blood pressure? That's the kind of thinking that you have to do. You have to put yourself in the place of the patient to do this. Yes.
Sir, I would like to stop the study as most of the participants have been recruited. There has been
All the participants have been recruited.
So, and it's just 6 to 7 months left. Results show that it is statistically significant with the RR of almost 1.4. And as per our protocol, we chose this method where
Ryan
we
Fleming?
would be, yes, where we would be stopping it. And we did not mention that even we would like to extend it for some more time. So I would go for the motion to stop the trial right now.
Okay, so she has made a motion. Anybody second the motion? There's seconding. Okay, so now you guys discuss it amongst yourself. You're not discussing it with me. You're discussing it among yourselves. And we're going to have you not necessarily reach a consensus, but you have to decide whether you want to stop or you want to continue. All right, so question. What is the compliance to the drug? That's a good question. I happen to have the answer to that. People are not stupid, right? Compliance at 1 year was pretty high in the active, and in the placebo was 87. It remains high in the active, but in the placebo, it's going down. Why? Because people that have systolic blood pressure feel it, and they know, wait a second, it's not going down. I don't feel this stupid medication. I must be on placebo. They stop taking the study medication. But we are analyzing this under intention to treat. So we are not adjusting the analysis for post-randomization people not adhering to things. It's just what it is. Despite people, maybe that's the reason we're getting this very high, but that's the way it is. Okay. Yes.
Isolated systolic hypertension. So in geriatric groups, comorbidity, multiple drug interaction, even though the outcome is a stroke, the patient on the antiplatelet therapy for a longer period, they're also subjected to the risk of a stroke. So impact of polypharmacy or comorbidity or adherence all impact to the primary outcome.
So yes, you raise a good point that these are elderly. They have all sorts of comorbidities. But the adverse event risks are few. The CVD risks are low as the incidence is small. Deaths are not significantly different. The primary and secondary outcomes are different between placebo and that. Table 1 again. Oh, baseline comparison. The table 1, I'm not going to show you, it's a laundry list of lots of stuff, but when you randomize 4,600, everything is comparable. So yes, they're comparable. There's no bias in assignment. Yep. Happy to show it to you again. And you had a question? Apart from what we're observing here, it's about 4 to 5%. So that's what we are getting. In the placebo, we're getting that 5%. And we plan the study for that 5. It's exactly, it's consonant with what you expected. So you thought that clinically important difference was, I think it was a even 1.5 difference. So going 3.5 to 5. So you're basically at what you had planned on their study for the difference.
So efficacy of antihypertensive drugs in the terms of controlled blood pressure and uncontrolled blood pressure.
So this is what you're seeing it, right? This is what you're seeing. So they are, this medication is lowering it a little bit from 5 to 3.6. So vote, show of hands, who would like to stop the study now? Okay. And who would not like to stop the study now? Okay. So you tell me why you want to stop the study, and you tell me why you don't want to stop the study. So you go first.
So I think because we have already achieved what we wanted to achieve.
So you crossed the boundary.
We have crossed the
and you're
boundary,
not
we have
there.
achieved.
Okay.
it. So
Why you don't want to stop the study? Mhm. Okay, so did everybody hear her? She said that if you look at the all reported, there's what, 12 or so more there, and there's 8 or more there, and you are still having to adjudicate. If we stop the study now, those reported potential strokes that are in the system of being reviewed will have to be counted in the analysis. And what if by bad luck, those that in the placebo are called, no, those were not really strokes, and those in the active are said, those are really strokes. So then you end up with 93 versus 119. And your Z value will now be just under that O'Brien-Fleming one. So you've stopped the study because you decided to stop the study or recommended to stop the study. And then when you do the final analysis, you are below the cut point. So that's what the committee felt. The committee felt we have these things in going on. So despite crossing it, they were very uncomfortable with recommending stopping. And if I go back to there, they said, we noticed that these go up and down, and they're here, they may come down. And when they come down and I've stopped the study, now I say, oh, I stopped the study and I'm not statistically significant. So they felt uncomfortable with this, and they said not 90 days, so let's meet again and review it again, okay? So you decided to do it again, and so you made again, and they did all sorts of other things. And now you are in this meeting in December of 1990, and look at what you did by not stopping the study. You caused so many more deaths in the placebo, I mean, not deaths, strokes, than in the active. Now your relative risk is 1.47. Huge. It's worse than that. The reported ones are also very close to that, 1.48. Deaths continue to be about the same. There's not, but look at all the more MIs you've done, all the transient and ischemic tests, how can you sleep at night thinking about what you've caused, the harm that you've caused to these people on placebo in this? Wait, one at a time, yeah.
Information we had at the time of the previous meeting, we tried to make the best decision
No,
possible.
so that's it. Everybody's doing that. Nobody's blaming you. It is human nature. We don't know the future. I'm just telling you what happened
Yes.
between that time and this time. Not blaming anybody.
So can
Now-
you see the O'Brien-Fleming boundary and
So
the-
now, yeah, you've really gone beyond the O'Brien Fleming boundary
yeah,
there.
gone.
So
And-
what, yeah,
No, just I mean I'm pretty sure it'll be above 1, but the confidence interval significant. 1
it's
point.
hugely
Okay, fine.
significant. now.
Okay, fine.
So what would you do? So again? Yeah, you still don't have some that are,
January
they
month.
still have, but now there's, 13 here and 8 here. So because they keep happening, right? But what makes you feel comfortable is that the relative risk is comparable, right? It was 1.4 and 1.41. Now it's 1.47, 1.48. So this is
Number of
tracking
tests.
that. It's not that it's very different from one to the other.
So what was the difference? What was the change in the number of deaths or the proportion of deaths?
Actually, no, it was 1.09 and it stayed at 1.09. That didn't change.
I would propose, I mean,
Yeah, so no, that the deaths include 1. So it's not significant difference in deaths between them.
I feel that, I mean, I would propose to let it go on with the 1 month left. Some more strokes will be adjudicated, which are under, which are still being adjudicated. We would get an answer which is definitive, and the trial would also end as per protocol.
So you're willing to let more people have strokes in the placebo?
If you put it, yes. I mean, if you have to put it that way, then yes, I'm okay to take that on my head.
So what do everybody else on the committee feel? How many of you want to stop? She's the lonely person that wants to continue. Okay. Okay. So there's 2, there's 3. You want to continue. So I'll ask you now, why do you want to continue? There's, yeah, so there's 13 here
Whereas
and
there
there's
is there
8 here.
8 here. So if the 13 go to the if the 13,
But
sorry.
now you've crossed the boundary by a lot. I'll get to the boundary here. So now, draw it again. Right? Yeah, I have it here. So the boundaries, I can. Where is that pointer? You see it? Ah, oh, here it is. So. So before, you had just crossed and you were worried about it coming down, but actually it went up even more. And this one, the reported ones are way up here. We're way, way up here. So it's unlikely that those 13 will make a difference, that will make you come down below.
The other has only 8. So
Yeah, but it still will not make a difference.
Are we bound by the
No. The boundaries are guidelines. They are not rules. Okay? Any other questions?
drug is a safe drug.
Vote and only 2 are
Is that a
against.
question?
What is the final decision?
So the reporting status, that's a good question. I, as the reporting status, the statistician who is not a member of the board, he's the person, he or she is the person presenting to the board, doesn't have an opinion. Now, board members have statisticians on the board. Those statisticians on the boards have lots of opinions. So all of you statisticians that are on the
So
board
one,
need to express your opinion too.
so currently the opinion of the board members, except Dr. Ablasha and Dr. Senior, is to stop. So if two people are voting against, what will be the final?
Well, so
decision.
usually the way it goes, first of all, they don't have 40 people on the board.
I know, but what
They-
percentage I
They
mean?
usually have 3 or 4.
Yeah,
And they try to reach a consensus because that is the main idea. When I was in the herpetic eye disease study, there were 5 of us.
okay.
There were 2 statisticians, there were 2 ophthalmologists, and there was an ethicist, medical ethics person. And the ophthalmologist, all from the first day, or not first day, first meeting, when we saw data, there was a clear difference that topical acyclovir was not as good as systemic acyclovir. Systemic was a whole lot better. And we statisticians said, oh, this is a reason to stop. The ophthalmologist said, oh, but we knew that this was going to be this way. What we want to know is the long-term effects of taking a acyclovir, for maybe it causes more problems, etc. Taking this corticosteroid, etc. So there's this poor medical ethics guy had to be the one. We would have discussions that we were supposed to meet for an hour or 2, and we met for like 8 hours. The people where we were meeting would bring us pizza for dinner, or and they'd knock on the door and bring us food and then go away. And we're still discussing. Yeah, we're still discussing.
And it will be minuted? All of these discussions will be minuted?
So the discussions, when we did not stop the study, where we met and carefully reviewed everything that was presented, and we did not see any reason to change it by the protocol. That's it.
Okay.
Didn't say anything.
Is there a reason for, so
This-
DSMB may stop the trial only if there is, it's near to complete. The DSMB may stop the trial in the initial, very initial stage and very late stage. There is only 2-3 months for completion of the trial.
So this is your reason for not wanting to stop.
If it's dead.
Sir,
Only one reason.
That's one reason for it, okay?
sir, may I know the reason why we have been following up the patients for this much time? Is there a rationale?
That's what's in your protocol.
No, because if we have a reason, like, why do you want to follow it for 5 years?
Because
Till then the planning-
in the development of stroke is a chronic disease. It doesn't occur instantly. So I give you something that lowers your
Why,
blood
then
pressure
why did we
and-
not follow them for 4 years?
because that's what the investigators.
So I know, I don't know the
So
subject.
no, so what usually the pharmacoepidemiologists would have estimated how much medication you have to take for that to have an impact in the person's rate
Yeah,
of stroke.
exactly,
They said
so-
4 years is what
Yeah.
they need per person.
So,
Like that other study was 7 years. Some studies may be 3 months. It depends.
why I asked is, sir, if we, within that 3 months, by like stopping the trial and giving the drug for some, we may not be actually giving a benefit of, because this is a drug, if it is like, that has to be taken for
For
some
the
time.
rest of your life, you'll have to take it for the
Take
rest
it,
of your
so
life.
if it's something that will bring an outcome within this 3 months or
No, it won't.
it won't.
No,
So,
you have to-
so,
This is
we're
something
not
that takes a long
denying
time
that-
for it to have an effect,
mm,
for it to be a meaningful effect.
so what if like the drug having taken for 4 years or
But-
this
But
much
one point is
cumulative?
that the DSMB does not redo the protocol.
No, not to redo the
Yeah.
protocol, but the reason for not stopping is we have put a point up to 5 years. So what if there's a cumulative effect of this drug, and in the next 3 months that's going to manifest, which we are not going to see.
We don't know.
We
Maybe the
don't know.
manifestation is in
And,
6 years from now.
Okay, but
knows?
6
That's
years
not
from
part of
now,
this study.
6 years from now is not our mandate in the protocol, but we have already said that there is, we have fixed a point, and what if something happened? And we are not going to get a clear benefit for the other group,
So you're
because the
trying to
very,
convince others that this is the reason. You're not convincing me. I don't have an opinion.
So,
I am the
uh,
statistician.
I
only.
might be backtracking on my motion because
Second backtracking.
because of two main concerns. Just if I could, one is that the participant adherence in the control arm has been steadily falling. So, and we can now see that there is a definitive protective effect of the antihypertensive from stroke. So they should benefit from it. Secondly, now the strokes, all strokes, that they have broken the pattern of going up and down. There is no chance of the the research team having a non-significant result if we stop it now. I mean, I don't think that that's going to happen. So keeping both those things in mind, we can stop it, because even if, I mean, looking at 1 month, one can say there's only 1 month, let it go on. But one can also say there is only 1 month, we can close it. It's fine. We have a long period of follow-up. So I think we could conclude, we could submit.
So this is the opinion of one of your board members. Yes.
So do we have any data about the temporal pattern or clustering of the strokes in both the groups?
Clustering of the strokes.
So the events.
Do they occur early or they occur late?
Yeah. So the I mean, is there a clustering of the events in terms of the 5-year follow, for example? So strokes have occurred across at a particular time point.
So the timing of the strokes. Yeah.
Because I think that's the important parameter for me. Somebody who's starting on an antihypertensive on a long-term basis.
It takes a long time before they're.
And so partly what she was talking about, but for me the pattern matters. So if you have a clustering of the more strokes in the placebo group at a different time point versus, then I need to look at some other factor rather than just attributing across it to the therapy person. I mean, that's one factor which biologically I would look at.
That is a very important point, that the time to the development of the stroke should have been what the investigators looked at. They decided in the protocol to look at the occurrence of a stroke within a 4-year period, yes or no. But this is a suggestion for that if they do I can do the calculation for you. And at the next meeting, I can present it to you if you're willing to wait. But it is not something that the investigators had.
So in view of that, so since the trial is left with only 1 month, I would rather continue with it.
You'd rather
If you want to continue, I think you should explain what you think will drastically happen in the next 1 or 2 months to justify.
What do you think that could happen? Yeah, that's a good
Yes,
point.
rather than statistics, here we are dealing with live or some here rather than statistics with like 1 month, 2 months, here we are dealing with one stroke and one live. If you would have stopped it first time, we have seen 40%. We are worried about few numbers. We can ask to take next meeting early, like not in 3 months. Next, we will compute everything, whatever is there. So taking meeting 2 days. 2 days to finish. Yeah, 2-3 days. We can ask them to take one more meeting and to finish it up that number.
So it's fine. We will convene a meeting in 3 days of all 40 of you. You're welcome to come back in 2 days, and we will. I can present it, or maybe one day I'll present to you tomorrow if you want to come back.
So, and the second.
But no, okay. We think nobody's going to bring pizza here if we keep deliberating. Loss to follow-up in both groups is very small. Let's see, I have it here. How good was follow? 99.8% complete. Very little differential. All right, so who votes to stop now in December? Does anybody vote to continue in December? I was looking at you because you were still.
I was just trying to calculate and see how we can just stop it. Yes, of course, we build utility of the intervention, but then
not utility, we proved efficacy. Efficacy.
But then there are also other factors to consider. Even if it's just a month,
no, it's part of, it's not deviation. You had it, adaptive design of interim analysis and stuff.
Next 2 months to justify not stopping the trial. If you don't want to stop the trial, what it actually means is you expect there is a chance that placebo group or the treatment group would develop 40 more people will develop stroke in the next 2 months to get finally a same number. So that is unlikely to happen. But you don't expect anything to happen in the next 2 months suddenly.
Okay, so the question is, can I calculate the conditional power for trend? So yes, I can give you that. So the conditional power actually is higher than what you had in July, but I'll remind you what you have in July. You didn't ask me to compute it for this time, so I haven't computed it for this time. But power is this curve here at baseline. But as we've accumulated data, the power curve shifts and goes up. So the conditional power for strokes is at the time of July was for final strokes, definitive was 63% and was 87% for all reported strokes. It was not quite at 80%, and that's in July. But now, my guess is that it's over 85%. Is there anybody that votes for not stopping? All right, Vishali votes for not stopping.
The reason is, so the reason what I would presume is because we're almost at the end of the trial. We're almost at the end of the trial. What we have is just, we've already finished the recruitment. The follow-up is also going to end because we are finishing in the Jan 1991. So this is in December 1990. So whatever we have, we just need to only the ones which are not really confirmed by the thing is what is left. So we're not really harming anybody who is in the placebo arm. So I think
we're not really harming anybody.
What I'm trying to say is definitely the recruitment has been done already. Right. So patients are already inside, and we are only trying to review whether they are confirmed strokes or not. Right. So, and then the time limit is just January.
But more events are occurring.
More events are
every
occurring.
Day.
Yeah, that's true. But still, I'm trying to say.
Okay, one at a time. Yeah.
So, like based on these results, intervention is already over. We are just following them. So
no. Some people that entered late are still getting intervention.
Okay. So as after this, as a responsible persons in DSMB, shouldn't we give a recommendation that all the other ones who are still in receiving placebo, they should also receive treatment?
Yeah. So that means stopping the study.
Yeah, after stopping.
No. If you say we recommend that people in placebo be given the medication, that means you're recommending stopping the study.
Yeah, we want to stop. After stopping, this is what we want to say.
After stopping, that's what automatically should happen.
So whose responsibility? Is it a trial investigator?
The trial investigator's responsibility.
The first time when we saw that it is borderline, when the psychology is borderline, it was like 1.4 or relative was 1.4. So during that time, we will stop the study, and now we worry about whether it's still 50 or not, whether it will go down. So we'll do one placebo, which is most of the trial they are doing that placebo patient, they are including into intervention arm, and after that they are doing post hoc analysis after 6.
Yeah, but then if you do that, you are changing now the study, and so you're essentially stopping it, and you will put everybody that's in placebo to this medication, and you'll do long-term follow-up to see if there's any problems with medication long-term follow-up. But the trial actually ends when you do it.
So I actually know the answer.
No, don't say it.
But I don't want to. That's why I'm just.
So. Yeah, the protocol must say that. I'm sure they said that because the ethics board forced them to say that. So it says that. So final vote is to stop. I'll tell you what the committee did. Vishali knows the answer. The committee decided to not stop the study. Can somebody guess why the committee decided not to stop the study?
So anything can happen in next 1 month.
Well, that is true, but that's not the reason why the committee did not stop. compliance has nothing to do with it. No, that has nothing to do with it. Several of you hinted that it's because we only have, 2 months to go. What happens when you stop a study early? I said yesterday. Funding, but you're not going to have to return a lot of money when it's just that. There's something else I said that happens. You have to, as investigators, tell the participants, thank you for participating in this study. You have been given 4 years of your life to take in placebo, and your husband died because he was on placebo. You have to invite them in. You don't send them an email. Email did not exist back then. You don't call them on the phone. You have to bring them, talk to them, have a trained psychologist tell them the study results. They don't want to read it in the newspaper. That's the worst thing that can happen. And it's called a proper closeout procedure. What is happening in December in the United States? Christmas time. All your staff has already planned going away on Christmas. Are you going to force your staff to come in and do it over Christmas and try to get people to come in over Christmas and New Year's and holidays? This is too much logistically to do. So they did not do it, mainly not for efficacy reasons, because they have crossed it, not for any other statistical reason, but a totally administrative, logistic reason they did it. And what happened then was the following. When the end of the study came, and at the end of the study, now the reported and the all are definite. You ended up here with a Z value of 3.5, ridiculously high. And when they published the result, a lot of people questioned, didn't you know that you should have stopped earlier? What happened to you people? What kind of a board are you that you did not recommend stopping the study early? That's when they wrote a paper to defend themselves and how they could not guess the future. And it's here. In 1993, 2 years later, they wrote a paper to defend themselves of why they did not stop early. That's where I got all the information. That's why I don't have all the data, because I only got it from that paper. Yeah, they may, who knows what had happened. Okay, yeah, so if you don't stop the study early and the trial ends naturally, normally you never mention any details of the interim analysis. You don't see any paper telling you, oh, we did not stop the study and we saw this, this, and this. They didn't do it here either. That paper, the original results, never said that they were doing interim analysis, etc. They said on the one line there was a data safety monitoring committee that looked at it, but here are the results. It's when people saw the Z value of 3.5, they called the people in question and said, what the heck are you guys doing? Yeah.
Are each of the participants informed of
Yes, they should be.
That's why I'm asking is, when I was a participant in the vaccine trial, in the Covaxin trial.
Nobody called you.
No one called me.
Well, this is what is medical ethics. People don't think about this. I said it yesterday. People don't think about their participants as real people. Yeah. Yeah. Yes, that's your role and responsibility. Yes, last question, because it's getting late.
So Why does this onus of informing the participant only when is important only when it is stopped early?
No. It's at all the times. Whenever you have a study, you get the consent of the participants to participate, right? And you owe it to them to tell them the results first before you tell the New England Journal. Now, most people sort of forget about it because they don't care so much for their participants. That's the problem. So from moral ethics of doing research when you're experimenting with somebody, you ought to be thoughtful of these people as other human beings. And so most people should. So it's a best practice to do so. That doesn't mean that people do it. They should. All right, we'll stop there.